Hello. Hi, everybody. Good morning, good afternoon, good evening, friends and colleagues from all over the world. I'm very pleased to be live tonight with, it's tonight in my country, in Albania, and it's around that also in Greece, with my dear friend, Dr. Loannis Vergoullis, which I have now online, and we're going to talk together in this next pod dinner about cervical and all the planning we have to do for supracrestal positioning of an implant and about how to place it best that you can.
Hi, Guren. Thank you for having me here. It's a great pleasure to be here.
It's a great pleasure to have you here, my friend. So, how's the weather in Greece? I see you are a little light.
Summertime.
Yeah. It's the same here, it's autumn, but we can't say it yet. However, we have our masks to keep us comfortable all around the places. So we are warm, however it is.
It's a difficult time, but we will go through it.
Yeah, of course, for sure. It's getting very bad now with the problems of COVID, but however, we are going to pass it, I believe. However, we are going strong. The dental profession is going to pass through it, and I believe we're gonna get it better, and we're gonna be stronger from it. So, my friend, how is it that you come up with the idea of cervical?
Well, everything started several years ago, and it had to do with several problems that we were dealing in the clinic related to peri-implantitis. And we were able to identify that a lot of these cases affected by peri-implantitis were associated with mal-design of prosthesis. So me as a surgeon, I was not involved into the restorative stage of treatment, but I had to deal with the problems of the patients developing peri-implantitis and coming back to my clinic for treatment. So I started looking deeper into the problem and discussing with restorative dentists and with the lab technicians. I was able to identify that there was a big problem, a big lack on the area of soft tissue conditioning. So basically, I will place the implant, I will put the stock healing abutment on the implant, and I felt that my job is done. So I will send the case to the restorative dentist. The dentist will take a regular impression, send it to the lab, and then we expect from the lab to make miracles and create a properly designed prosthesis when we have not taken the time to properly shape the soft tissue. So the design of the prosthesis resembled like a mushroom shape design with big areas of undercuts and ridge lap. And of course, when you install this to the implants, it's easy to ask from the patient to clean, but you don't provide access to the patient to control the plant.
That's true. That's true. So, most of the time we...
Yeah, so basically, the lab flip it back to us, to the restorative and the surgeons, and they said, okay, you guys need to take care of the soft tissue. And I went through literature and I discussed with several colleagues of mine that I have very high respect, and I was able to identify different ways of doing that. However, there were several problems associated with every method. Either they required a lot of time, they required expertise, they required higher cost. The cost of treatment was getting raised, and nobody wanted to take this cost, neither the patient, nor the surgeon, nor the restorative dentist.
Of course.
So I came to realize that the best way to do that is by installing anatomical healing abutments on the implants and taking care of this issue from surgery. But the problem was that back then there were very few companies had anatomical healing abutments, and the ones they had it, they were very expensive. So for me, this would require like an increase of about 30,000–40,000 euro in stock in order to have different shapes.
No, the problem is also that, I'm a user of anatomical abutments from about 10–15 years, but you have to trim it, I had this big plastic piece of TSM. It's not a regular plastic, and I have to trim it in the right shape to place it over the implant, which is not as easy, It requires some lab skills that not all the dentists have, That's why So the company wouldn't sell it for a high price, but however, it's not much guys like me that would use it because it was not easy to use it. It's so cervical. It's much easy.
It's not easy to modify it, and it's not easy to polish it and give the surface the proper properties after you modify it. And the big thing is that it's okay to buy one anatomical healing abutment, pay 120 euro, buy one, do one case, document this case, show it in a podium or on Facebook, and you are. But this is not the issue. The issue is how can I make this daily practice?
Every day.
No? So I developed with a local lab here a very modest prototype. And then I got to meet George Paps, who is a certified lab technician, and he has a big company in the dental laboratory field on creating amazing tools. So we joined forces and we developed this little crappy prototype into a beautiful tool where everybody can use it, and for any type of implant. And then we tested that for almost 2 years in the clinic. We wanted to make sure that it works perfectly fine, no matter what the skills and the level of the dentist is. And then, seeing the potential, we got it out in the market through a company, which company is called Innovato Holdings.
Yes, that's how I found you. A couple of guys were speaking about it, and then I saw the potential, and I came to speak with you. You remember it? It was several years ago, but it's really an amazing tool. It made my work, my life much easier, because you say you do only surgery, but I have most of the time to do also the prosthetic part, and it's not that I can pass the ball to some other guy to and cheat to myself. That's why I have to do it and try to make it work better for me. So I've seen the potential of cervical, and I'm using it now. It's amazing. You can pass directly. The patient comes in. You can see what's going on. And it's very good that you can plan it in already. I like digital, but some things they require your skill, and this is one of those. It's not that you can skip the human part and talk to a guy through a computer and explain it how it's going to be. At least this is my point of view.
The main thing is we need to understand that it is very important to shape the cervical profile of the soft tissue. It is very important. And I will go through my presentation that by doing that and by following some simple steps, we can reduce the amount of cases affected by peri-implantitis about 75%. And this is huge.
That's huge.
Do you want to do that by utilizing dynamic compression technique, by utilizing immediate placement, immediate loading, by utilizing cervical, by utilizing a prefabricated custom healing abutment from a company? It doesn't make any difference. This is marketing. This is other stuff. What matters is, as dentists, for us to understand that we need to do this. Then we need to figure out ourselves what is the best way to do that. And for me, I was looking for a solution that is easy, it's fast, and it's cost effective. Because I don't charge my patients. Increase of prices, economical crisis, not increase the prices of my surgery. So I needed to provide a better result, but keep the prices the same. So this was fundamental for me.
It's fundamental all over. With the crisis, you can't go on and tell a guy you're going to pay just for the project and me to think about it a couple of €100 just like that. They don't accept it most of the time. Even the guys that got money, they wouldn't go and say, let's give you this money. It's like being an architect.
But I will tell you something. We explain to the patient, my assistants explain to the patient that we will utilize a customized healing abutment that resembles your anatomy. We will not utilize something stock that the company offers because This way we can provide superior results, blah, blah, blah. And we will not charge you anything extra. We do that because we care. And the patient doesn't really understand what is a stock healing abutment, what is an anatomical healing abutment.
Normally, no.
The same way they don't understand if you are utilizing implant A or B or C. But what they understand is if you, as their doctor, if you care about them, and if you try to provide quality treatment and superior results, this is what is all about them understanding that we care.
Well, the problem, this is what brought them to us in the first place. It's normally, for me, for example, it is that a guy told them that this guy is good and it's going to do a good job for you and my implant looks good. You can't see where my implant is. That's the best possible advertise that you can give to someone else. It's not that they are going to go to details to tell them he took my shaping of the implant and they put it 2 millimeters deep inside the bone. They don't know that. Nobody understands that. It's difficult to understand even for dentists. So normally it's the result that counts. And with the technique that Cervic offers, I've seen this. But you, of course, can speak much better than me because you've been, using it, trying it for more time, and now I believe it's time to let you go on with the presentation because I know you've got lots of stuff to say and a little pressure of time. What I have seen.
I will try. First of all, I will show why it is important. And for me, it's very important for people to understand the biology behind the system. And the system was designed based on a lot of biologic principles. And it was designed in order to work for the dentist and not for the dentist to work for the system. You mentioned digital technology before. And I see people that they utilize digital technology in their favor, but I see other people that they struggle in order just to utilize digital technology. And this is not the goal. And by that, I would like to say, for first time here, that iCervico is under clinical testing. So we will be marrying the digital and the analogic world in an amazing manner, again, an innovative way. And we prove our innovation through the patents that we hold globally in USA, Europe, and other countries. And I'm really excited for 2021.
But you were saying me a little before, a little joke about the digital. You care to say it, to share it with the public now?
That was private.
Well, it's not many people around. It's just a couple of thousand of guys, I believe. No, not many. So pretend we're together. But it wasn't even something, indiscreet. So you can say it, I believe.
What I was saying basically is that I was giving a lecture in one country, and there was a great dentist, very well-known dentist in that country, and the dentist told me, "Well, that's a great system. It really looks amazing, but I'm utilizing prefabricated custom healing abutments from company X already." And I said, and I'm a KOL for this company, and I said, if you get them for free, then it's an amazing solution. Keep doing that. Probably you don't need Cervico. So, but if you don't get them for free, then you need to do your math and see what is the cost and what do you invest on this. And it's funny that I saw a couple of days ago a picture, and I saw this dentist lecturing about Cervico.
Well, it's you have to try to believe, and of course you have to do the math. And I believe the math is going to get right. And I believe you're going to explain how the math goes. So good luck with the presentation. We will discuss later on and come up with some questions.
Okay.
Okay.
So I will speak today about modern implant concepts and how they relate to Cervico. Like we discussed before with Guren, when we look at our cases, we will see that we have cases that they are stable over time, but we also have a lot of cases that they present with failure. And we want to present stability, and the longer we have stable results, the better it is. And if we look at our failures, we will see that the big majority of the cases are related to peri-implantitis. So peri-implantitis is the #1 enemy we have in order to prevent bone loss and failure of the implants. And if we look at peri-implantitis, a conservative estimate from systematic review and meta-analysis shows that about 20% of our cases can develop peri-implantitis within 5 years. And in the real world, these numbers will be even bigger. We see huge range. And of course, this has to do with the research, the implants used, and also the methodology that was utilized in order to identify and categorize peri-implantitis. But nevertheless, these numbers are very alarming. And we know that peri-implantitis is a very aggressive disease. And my friend George Kotsakis showed that basically we can have peri-implantitis development even within the first year after we place our implants. What about treatment? If we do have peri-implantitis cases, how do they respond to treatment? Well, it looks that things don't look very promising. And this study by Esposito showed that we can have a relapse even to about 100% of our cases within 1 year. Of course, there are certain ways that we can treat. It depends when, at the time that we interfere. And again, George, who is an authority on peri-implantitis treatment, is about to reveal some new exciting news, and things look a little bit more promising. But with what we have available right now, it seems that if the implant develops peri-implantitis, then it's very hard to control this and avoid failure. So that means that we basically need to focus on prevention. We need to prevent peri-implantitis. And in order to prevent it, we have to look at two factors: the host response and the treatment protocols. And when it comes to host response, we need to understand that not every patient is a candidate for implants. I personally do not hesitate to exclude certain patients from implant treatment. And combination of smoking and history of periodontitis, for me, it's a no-no for implants if I have alternative solutions. What about treatment protocols? The surgical and restorative protocols are also very important in our efforts to prevent peri-implantitis. Of course, in 30 minutes, I cannot go into detail on this. I will basically focus in my area of interest, and this is where everything starts. In the transmucosal zone, in this small area of soft tissue above the bone crest, above the implant platform. This is where everything starts. But we need to understand that we cannot look into this area only from the perspective of the soft tissue, but we have to take into account also the part of the prosthesis that is located within this area. And now we have a complex of interaction between the implant prosthetic part and the soft tissue part. And this is something that we have submitted for publication with Nikos and Alberto and Dr. Jada from Sweden, and the Supra-crestal Implant Complex. And hopefully this year will be available. And when we look at the Supracrystal Implant Complex, there are two areas of interest. The first one is the cervical profile, which is the cervical margin of the prosthesis, which lies on the cervical margin of the soft tissue. And then we have the submergence profile, which is the area below the cervical profile and up to the implant platform. And this supracrestal implant complex, this interaction of the hardware and the soft tissue in this area is biologically important. Why? Not for aesthetic reasons, but for biologic reasons. We have to look into biology. And when we look at the soft tissue, we know from back in 1999 that in this area we have something called the peri-implant seal. And what is the peri-implant seal? The peri-implant seal is the zone of the connective tissue and the junctional epithelium. These two zones adhere on the implant surface and on the abutment surface, and they isolate the area of the bone, of the crestal bone around the implant, and they protect this area from the plaque that is located within the sulcus. And how can we build this peri-implant seal? It's very simple. We need to provide enough soft tissue height, what people talk about call as biologic width. So basically, again, we know that we need at least 3 millimeters for the junctional epithelium and the connective tissue to properly form. And we have a variation. We need to understand that all these numbers that we see in different lectures, including this one, these are average numbers. And we have a range, we have a standard deviation between different individuals. If we look into human histology, we will see that this biologic zone, this area of peri-implant seal, requires anywhere from 3.5 to 5 millimeters. And of course, this is related to the individual. It is related to the final position of the implant platform in relation to the bone crest. For instance, if you place your implant subcrestally, this zone will increase. However, when I go in my clinic, I try to be practical, and I have to pick a number. And for me, the magic number is 4 millimeters. And this is not something that came out from a magic clear ball. It's based on this study back in 1996 from Berklut and the Göteborg group, where we can see that if we have 4 millimeters of soft tissue above the implant platform, we don't lose bone. While if we have 2 millimeters or less, then we lose bone in order for the seal, the peri-implant seal, to be formed on the implant surface in expense of the bone. So that's how I utilize the 4 millimeter number. But when we place our implants, we need to understand that this 4 millimeter does not necessarily relate to the height of the soft tissue above the bone crest. It relates to the distance between the implant platform and the zenith of your prosthesis. So sometimes, like in this case that I have put here, we have excessive soft tissue height. You see, in this case, I have almost 7 millimeters soft tissue height above the crest. But if I correlate the implant position and the zenith of the prosthesis, it's very clear that I need to place my implants deeper into the bone. The second factor we need in order to build the peri-implant seal is biocompatibility. It is very important to provide biocompatible materials, and we know that titanium is a biocompatible material, and zirconia is a biocompatible material. And what do I mean by that? We need to provide a surface where hemidesmosomal attachment can be formed, and hemidesmosomal attachment is what we see at the junctional epithelium. If we utilize porcelain and we expand the porcelain all the way to the implant platform, porcelain is not a biocompatible material. It does not allow this adhesion, this attachment to happen. So we end up with a deep pocket all the way to the implant platform. And we know that back from 1996, from the studies by Abrahamson and Göteborg group again. Okay, we built the peri-implant seal by providing enough soft tissue height and biocompatible materials. Another question is, how can we make this seal stronger? We're talking about a defensive mechanism against the bacteria. So how can we make this stronger? Well, we need to improve the blood supply. And if we look at histology, we will see that basically in the area just above the crest, where we want the peri-implant seal to be formed, this is an area that is poor in blood supply. The only blood supply, we have lost the periodontal ligament blood supply because we lost the tooth, and the only blood supply we get is from the supraperiostral vascular complex. And if we have enough bone width, we can have some intraosseous blood supply as well. So we need to provide for better blood supply, and we can do that by providing better thickness of soft tissue and hard tissue. And we can do that either by augmenting the bone or the soft tissue, and at the same time utilizing implant systems and prosthetic parts that comprise platform suites and concave type of components, so that we minimize the hardware, the expansion of this hardware into this space, and providing for more room for the soft tissue. Okay, we build it now a strong peri-implant seal. The next question is, how can we maintain this stable over time? Meaning, how can I make sure that this seal will stay there where it is for 5 years, 10 years, 15 years and serve its purpose? Well, the first thing is we need to avoid multiple connections, disconnections. We know it's very clear from the literature that if we do multiple connections, disconnections, this will lead to soft tissue recession and then hard tissue recession. Why? Because this peri-implant seal is very fragile. This connective tissue and this junctional epithelium are very fragile. And by doing multiple connections and disconnections, we destroy them and we lead them to recede further down. And we can avoid that either by utilizing intermediate abutments like the connect abutment or the single unit abutment. Now, most of the companies have this type of components, or by improving our prosthetic protocols in order to avoid multiple connections, disconnections on the implant, meaning taking a good quality impression and moving straight forward from the impression to the final prosthesis. We know that if we minimize to up to 2 connections, disconnections, we will not have an issue. The second thing we need is for the plaque to be disturbed regularly. The same like teeth, the implants will have the plaque being formed around them from the moment we connect the suprastructure on the implant. So it's the job of the patient to apply oral hygiene. And we need to show to our patients how to do oral hygiene and what kind of toothbrushes and what kind of toothpaste that they can use. For instance, we cannot utilize fluoride toothpaste on implants. We cannot utilize chlorhexidine products on implants, as we know that they can alter the topography and the surface, the titanium surface of the abutment at first, and then probably the implant itself, and release ions, and in some patients create titanium intolerance, etc., etc. So it's very important that we guide them, but at the end of the day, the patient needs to apply proper oral hygiene. However, we need to provide accessibility. We need to make this process easy for the patient. So if we can do that by conditioning the soft tissue, we need to take the time and condition this cervical profile of the soft tissue so that the cervical profile of the tissue matches the cervical profile of the prosthesis. And it's very simple. Think about classic perio literature. If we have prosthesis with overhangs, with ridge lap design, these prostheses, these parts are very susceptible to accumulate bacteria. They are very difficult to be reached by the patient. So it's almost a mission impossible for the patient to access this plaque zone and disturb it. So it's easy for us to tell the patient, brush thoroughly, put the floss and go under the, but come on, it has to be easy, okay? So it's our job to make it easy. And how important is that? Well, if you take care of the soft tissue profile in order to match the profile of the prosthesis, the cervical profile, you can reduce your peri-implantitis cases by 75%. And I get this conclusion based on these 2 studies where they evaluated cases affected by peri-implantitis, and approximately 75% of these cases were related with badly designed prostheses. And the prostheses are badly designed either because the lab technician and the dentist, the restorative dentist, have no idea about basic biology, but this is not the case most of the times. Most of the times it has to do with the non-conditioning of the soft tissue. You don't have the proper shape of soft tissue for the lab technician to design properly the prosthesis. So you need to understand that when you deliver this type of prosthesis, it's only a matter of time before they get back to you problematic and you have to repeat. So based on this, you can understand that taking care of the cervical profile for biologic reasons in order to prevent peri-implantitis becomes way more important when we move backwards towards premolars and even more for molars, where the size of the prosthesis is bigger. While for anterior cases, taking care of the soft tissue profile is important, mainly for aesthetic reasons. And the question is now, okay, if I need to do this for every case in my clinic, how can I do that? I'm not a prosthodontist. Well, if we look at the literature, there are certain ways that we can utilize. For me, in my clinic, the easiest way to do it, the most cost-effective way, was by just utilizing an anatomical healing abutment. So instead of screwing a stock healing abutment on the implant, I just utilize an anatomical one. And if we look at the literature, again, there is evidence that an anatomical healing abutment can provide superior results when it has the proper design and stretches the tissue and provides space. And not only for soft tissue thickness, but also for as far as the orientation of the fibers and plaque infiltration in the area. And we see that in our clinic over the last 5 years, that Just by manipulating the tissue at the time of implant placement or uncovery with the use of an anatomical healing abutment, we improve the dimensions of the soft tissue. And these dimensions are very important, as we showed before, in order to get better stability, better blood supply in the critical areas. If we look at this study by Beretta, we will see that when they utilize anatomical healing abutments, they got better aesthetic results, but most importantly, the patients reported less pain. So the procedure of restoration was less painful for the patient. And at the end of the day, the patients, one of the main things that they evaluate when they come in our clinic is if they felt pain or not. So what about anatomical healing abutments? What choices do we have? There are several choices. I don't have time to go into detail for every one of them. I will focus on cervical, for which I have a financial interest, as you know, because I'm a co-inventor of the system. But we developed cervical with my dear friend and partner, George Paps, who is a certified dental technician, because I needed something in the office that I can provide me solutions in fast and cost-effective manner. And cervical basically comprises a guide that I utilize in order to identify the right healing abutment. What size, what shape healing abutment do I need there? I cannot just use my eyes and evaluate. I want to be accurate. And then my assistant, not me, my assistant, in the mold of the system, by utilizing a temporary abutment that I have available from whatever implant company and some composite material, she fabricates this healing abutment within a few minutes for me. And so the only thing I need to do now is screw on the implant this cervical healing abutment instead of screwing a stock healing abutment. And this way, I condition the soft tissue right there from surgery. Either this is the time of implant placement or the uncovery. Most importantly now, at the time of impression, my stock impression post can be used with the mold of the system, and now I can have a duplicate impression post. I can have an impression post where the subgingival profile is the same like the one of the healing abutment I used. And this way, I get predictability. I can record the developed profile every time predictably. Why? Because the composite is recording it. So I'm not affected by blood, saliva in the area, or like if the patient is difficult or easy. If I have multiple implants, the composite supports the soft tissue so it doesn't collapse by the time I move to take the impression. And of course, with cervical, you can fabricate healing abutments in different sizes and different shapes for anterior, premolars, molars, upper molars, lower molars, whatever you need. You can get something that has an anatomical shape that will always be very, very close to the exact dimensions of your patient. And you, as I said, you can utilize it for anterior teeth, where from a flat type of architecture, I go to this profile and I record and give this to the lab. I can do the same for premolars, and I can do the same for molars. So this becomes like a routine in our clinic. It's very easy, very predictable, and it doesn't require special skills in order to be achieved. But more than that, more than healing abutments and impression posts, we also utilize the cervical system in order to fabricate anatomical temporary abutments or even directly build temporary prosthesis. So it's a tool that can be utilized in order to customize in an anatomical shape any kind of prosthetic component, either one piece or two pieces. It doesn't make any difference. Whatever prosthetic part you use, it can be customized in shape. And basically, cervical, you need to understand that it controls the cervical profile. And this is where the name came from. And it was an idea of Nitzan. Nitzan gave me the idea, and I think Nitzan is a wise man. I took his idea, I took his recommendation, and this is how we came up with the name of the system. Because what we really control is the cervical profile. When it comes to the emergence profile, by default, the system gives you this S-shape emergence profile that has been shown to be the most favorable biologically. And you can utilize two different silicone inserts in order to provide for centric or eccentric healing abutments. Eccentric healing abutments are very useful in cases where you place your implant more palatally or more lingually, like in immediate implant cases. But remember, this is composite. You can modify it when needed. What about the prosthesis emergence angle? This was something that we really put a lot of thought in when we were designing the system. And we know that an acute, a wide emergence angle, prosthetic emergence angle, is associated with peri-implantitis. On the other hand, we saw from Alberto Micelli cases and the umbrella concept that this was not true. And it wasn't until this study came out from Yi where I was able to understand better what is going on. And it seems that what is important is not only the emergence angle per se, but also the emergence angle of the abutment shoulder. So it seems that when the abutment shoulder is very short, then you need to avoid wide prosthesis emergent angles. But if you utilize a longer shoulder and provide space for the soft tissue, then this prosthetic emergence angle might be of less importance. And the cervical system, like I said in the conversation I had with Guren, it allows you to utilize implant replicas installed into the mold of the system in different depths that basically replicate the different surgical protocols of the different implant systems. So some of my implants, the implants that I place in my office, I place them crestally because of the type of prosthetic connection they have. But I also have some implant systems that they have conical connection, and I place them subcrestally. So the system allows me to fabricate custom healing abutments with proper dimensions and emergence angle for the different clinical scenarios. Like you can see here, for crestal, 1 millimeter subcrestal, 2 millimeter subcrestal, and 3 millimeter subcrestal placement. So basically, this way, I don't need to modify the anatomy. I don't need to modify my surgical protocol. The same way that you will have probably to do that with a prefabricated titanium healing abutment. Here, I don't need to do that. The system gets adjusted to my needs and not vice versa. So basically, the cervical system will allow you to create a cervical profile in a dimension anywhere from 3 to 6 millimeters from your implant platform, depending how deep is this implant platform placed in relation to the crestal bone. And for eccentric healing abutments, we add 1 more millimeter in order to give this extra room for the emergence profile to be developed, accommodating for the more lingual position of the implant. But what also is very important is that the custom healing abutments of cervical are made out of composite material. So you can modify this and you can change angulations, you can change the shape, and you can change the height. Okay, what about biocompatibility? I hear some people talking about, okay, but composite material is not biocompatible. And we need to understand that biocompatibility, there is a long-term and short-term biocompatibility. And it is related to how the material behaves in relation to the tissue. So we have the studies by Saito that they showed that if the composite material is clean, you can have hemidesmosomal attachment being formed on its surface. So it seems a material, the epithelium can attach on the surface of the composite when the topography is proper, meaning proper polishing, proper cleaning, then this material is biocompatible. It cannot be non-biocompatible and hemidesmosomal attachment to be formed, like the same way we have for porcelain, where hemidesmosomal attachment cannot be formed. But keep in mind that the directions and the guides that you get from cervical is to utilize a temporary abutment where the shoulder of the abutment will have proper height to allow the connective tissue adhesion, while the composite is restricted in the area of the epithelium, where the junctional epithelium will be formed. So it is very important to polish really well the composite and clean it really well. If you don't polish the composite really well, again, the epithelium can attach. The epithelium can attach even in rough surfaces. It doesn't need a polished surface. However, there are studies that they show that in polished surface, we can have a better spread of this epithelial attachment. But we focus on polishing this composite very thoroughly because we don't want this surface to be amenable to plaque adhesion. We don't want the bacteria to be easily colonize the surface. So that's why this is a main reason that we strongly recommend to polish the composite surface. What is of paramount importance is to really clean this surface. If we want the cells to attach on this surface has to be clean. So conclusion. Cervico is a system that can enhance our results through the principles I show you. And the whole design of Cervico is based on three elements, providing space, protecting, and supporting the soft tissue. So putting into the biology into practice, I will show you now a clinical case of how we utilize Cervico on an everyday basis. This is the case where came into our clinic and we have a missing tooth. I utilize Cervico guide in order to identify the size of the denture space so I can relate what implant platform size I need and what I can place safely or not. And this tab, this cylindrical tab, I utilize it now as a surgical guide. I basically align the central line of the tab with the occlusal line of the teeth, and I drill through there in order to mark the entry point of my osteotomy. This way, I make sure that my osteotomy will be at the center of the prosthetic space, not mesially, not distally. No matter how good surgeon you are, there is something called parallax effect. So based on the angulation that you look into the surgical site, it's very easy for you to place your implant more mesially or more distally, while for your eyes, you are right at the center. So this way, I take this subjective value out of the equation. I make sure that I have the osteotomy position at the center of the prosthetic space. I raise a flap, or you can do flapless. I'm not a big fan of flapless. I like to raise small flaps. I put the pin of the guide, and then I install all the tab on the pin of the guide, the anatomical tab. What is the anatomical tab? This is basically a replica of the cervical profile area of the healing abutments that you can make with the cervical mold. And M2 stands for upper molars. So you see that I have three sizes, small, medium, large. So I can utilize these three sizes right there in order to make sure that the custom healing abutment, that my osteotomy is at the right angulation and position, and at the same time choose the right healing abutment that I need for this case. So I can either tell my assistant now that I will utilize the M2 upper molar small size healing abutment, or what I do over the last 2-3 years, which was an idea that I got from Mike Picos. I have a small stock ready, so basically I just say I need this healing abutment, they only disinfect it and just throw it on the surgical table and I have it ready to be used. So this is the implant now in position. I connect with the implant, the cervical healing abutment. And you can see that by utilizing the components of the system, the guide of the system, I'm able to do my placement prosthetically driven. I respect the prosthetic principles. And if you respect the prosthetic principles, you will always be within the safety zone of the surgical principles as described by Boozer. Your implant will always be within the safe zone. So now, do I put the healing abutment at one stage, or do I just put a cover screw and put the healing abutment on the second stage? It all depends on the initial stability and some other factors related to the patient. If the patient is a smoker or non-smoker, if the patient is healthy, non-healthy, if he's compliant, non-compliant, etc. Whenever it's favorable, I will do one stage. Why? Because this way, along with the bone osseointegration of the implant, I allow enough time for the soft tissue maturation around the healing abutment, and I don't delay the treatment of the patient. But I need to have good stability. Why? Because I need to torque this cervical healing abutment on the implant the same way I will torque a final prosthesis. Why do I torque it? Because I want to immediately get cold welding effect. I want to have micro stability between the prosthetic component and the implant. I don't want to have any micro mobility because it can have a negative impact on the healing potential of the site. Also, I want the patient, after the sutures are removed, to be able to brush and keep this healing abutment clean, the same way they will do for a regular prosthesis. Why? Because we know that the plaque will be formed immediately around this healing abutment. So we need to get the patient into this fight of the plaque zone immediately. This way now, I don't have to worry, since I torque this healing abutment, I don't have to worry for this healing abutment to becoming loose and having the patient calling me that the implant is moving or that they swallow this healing abutment, etc. Then the screw access hole, I like to utilize Blue M. This is a great material. It has an antibacterial effect, and at the same time is tissue friendly. It's not cytotoxic. the same way chlorhexidine is for fibroblasts. So I like to utilize sterile Teflon tape soaked on blue M gel. I put it in there, and then I just seal the screw access hole with some composite material. And this is 4 months later. 4 months later, we remove the healing abutment, and we can see how nicely the cervical profile has been created. We can basically, in a way, see the anatomy there with the deep connective tissue zone, where you can see it at the first 2 millimeters above the implant platform, which is really red and circular, and then you can see the stretching of the epithelium with bleeding, with the presence of bleeding, which is an indirect way to testify that we have some type of hemidesmosomal attachment there on the composite surface. And what do I need to do now? I need to record this accurately and send it to the lab. So I utilize a duplicate impression post that we created in the same well of the silicon of the cervical mold. And we have a technique that is published in the Journal of Implant and Advanced Clinical Dentistry. You can look for it in the ResearchGate, and you can download the article. It is available there. And now we have a very stable impression, because we have all this composite surface that provides enough volume for the closed strain pressure post to be locked into the impression and not present vertical or lateral mobility. So this is going to the lab, where my lab technician now here, she created the working model, and you can see that whatever we have in the mouth, this is what she has on the model. Now she needs to design a proper prosthesis. Remember, the supracrestal complex is two parts. It's the soft tissue and the prosthetic part that will go and house within this soft tissue. So when she designs that, what the directions we give is that we need to match exactly the cervical profile of the soft tissue with the cervical profile of the prosthesis. And we need to support this cervical profile of the prosthesis. While at the same time, below that, sometimes we are dealing with a problem where the prosthetic components of different implant companies might not match the exact dimensions of the soft tissue the way we created it. So what do we do then? We provide more space for the soft tissue. We don't choose wider prosthetic components in order to push this soft tissue. It is important to fully support the cervical soft tissue, but below that area, we can utilize more narrow components, giving space for blood clot to be formed, and this area will be filled with soft tissue. As long as this blood clot stays protected and the cervical profile stays supported in order not to collapse, this area will give us even more soft tissue. And this is how she designs the prosthesis. Most of the times we utilize full monolithic prosthesis, screw cemented. Sometimes we can utilize lithium disilicate in combination with zirconia prosthesis. It is very important, as several studies have shown, and Thomas Linkevicius has shown beautifully, and he has a great book that I strongly recommend for everybody to get access on this book. We need to polish this surface of zirconia really well. Remember what I told you, it's not just about the junctional epithelium adhesion, attachment, it's also for better spread of this junctional epithelium attachment, and also providing areas with less susceptibility to plaque adhesion. And this is the prosthesis, this is the try-in. And here I want to say that if for any reason we strongly, we almost 99% of our prostheses are screw cemented prostheses. We want to avoid cement sepsis cases, and also we want to provide prostheses that they can be easily retrieved if needed. If for any reason we need to utilize a cemented prosthesis, then we always try to provide for a custom final abutment like the one you see on the left of your screen. Why? Because this way we shift the cementation margin way up and out, so that this cement can be more easily controlled. Please keep in mind that it's almost impossible to control cement that lives underneath the cementation margin. I have tried to deal with a lot of cement sepsis cases. Even with an open flap, it's tremendously difficult to remove this cement, especially specialized implant cements, way worse than Tempont. And it's a pity to lose an implant just because of some cement remnants that left, went underneath there, stayed undetected, and created a problem that you will see a couple of years later. You are not going to see it immediately. So this is now the prosthesis that will be tried in, and this is, like I said, a combination of a tie base, custom zirconia, and lithium disilicate, and this is installed into the implant, and this is a 2 years follow-up where we see a nice integration and things look stable. Of course, custom healing abutment has a huge advantage in cases of immediate implant placement. Whenever I can place an implant immediately and I have enough stability to connect a healing abutment, then I will do that. Why? Because this way I immediately support the cervical profile of the soft tissue. I contain the graft. I don't need to put any sutures. I don't need to put any pressure on the tissue, and we see amazing results. Amazing results which are really make a difference when we look at lower molar sites. In premolars and upper molars, you might not see a huge difference if you take care of the soft tissue in second stage, but in lower molars, we do see a difference, and we're trying to put up, we're putting data together to write a paper on that, and hopefully we will have this available at some point soon. Please keep in mind that if you just put a stock healing abutment like you see in the right side of the picture, what usually we as surgeons do, we don't like to see open wounds. And we will go now and put sutures there and start pulling this tissue inside in order to cover this graft. So what do? We try to maintain the dimensions of the ridge, but at the same time, we go ahead and we pull this tissue and we apply pressure on the buccal side of the tissue in order to close everything. And of course, when we put a lot of sutures in this area, in this critical area, what we do is we introduce an oxidative stress in the surgical site, and this is something that is detrimental for the goal that we are trying to achieve. What about PET protocols, socket sealed, root membrane technique? No matter which of these techniques you use under the umbrella of PET, with cervical healing abutment, you can modify this healing abutment in order to ensure that you have proper space between your healer and the root seal. And this is very important because if you use a stock healing abutment, which you cannot modify, a lot of times you need to reduce and bevel even more the silt, and to the point that it might become dangerous for this silt to be dislodged or break. Again, with cervical, instead of modifying the silt, what we do is we modify the healer. And of course, it is important to duplicate this during the impression process. Now, what about cases where you cannot place your implant immediately and connect a healing abutment immediately? So, case scenarios where I cannot place the implant and I need to do ridge preservation technique, or I can place the implant, but the implant has very low stability and I cannot connect a healing abutment on the implant. So I will treat it again as a ridge preservation procedure, with the only difference that the implant now is within the socket. This is a technique which, again, we published in Journal of Implant and Advanced Clinical Dentistry. Again, on ResearchGate, you can find the article and download it for free. And this is a technique that I have been utilizing now for more than 2 years in the clinic, and it has changed the way I'm doing socket preservation. So basically, when you take the tooth out, you utilize the guide of the system in order to identify the cervical profile of your socket. And then with the mold of the system, you make 3 custom parts. The first one is the cervical socket plaque, which is basically a composite barrier. The second is the cervical healing abutment, and the third is the cervical impression post. So what do? I take the tooth out, I clean the socket really well, I fill both the hard and soft tissue zone with allograft, corticocancellous allograft, and then on top of this graft, I immediately place this composite barrier, which I connect with the adjacent teeth. No sutures. Then 3 months later, when I remove the composite plaque, you can see that I have an outline of the cervical profile, and I have the very thin layer of epithelium underneath that. Is that a surprise? Not. It's not a surprise. If we look at studies by Tarnow, where they utilized ovate pondix over extraction sites, we will see that this group has already shown that this is possible. The only difference is that now we don't have to prep the adjacent teeth. We just make an ovate pondic plug with the cervical system, and we just put it on top of the socket and connect it to the adjacent teeth. So now I place my implant and I immediately connect the healing abutment, cervical healing abutment. And this is the soft tissue profile that I get 3 months later. And now this I recorded with the one functional position technique by utilizing the custom impression post, send this information to the lab, and the lab creates this full zirconia prosthesis, which now we install into the implant. So without doing any kind of major surgery, without doing extensive soft tissue grafting or bone grafting, very simple steps, and we end up to a very acceptable result. So I hope I was able to show you that the cervical concept of treatment and the cervical system of tools is a great tool that you can utilize in order to optimize this supracrestal implant complex. It's not the only way, it's one of the ways. And based, like I told you before, based on these studies, if you just take the time in order to properly condition the soft tissue and provide a proper prosthesis with proper design made out of the proper materials, you can reduce the amount of failures related to peri-implantitis by almost 75%. And this is huge. We have several publications, and now I'm happy to see that several researchers around the globe are working with cervical, and they're trying to publish on cervical. For me, it's very important that we do understand that surgeon, restorative dentist, and lab technician, we are all one team. And we need to be on the same level, and we need to follow the same philosophy. Otherwise, the chain will be broken, and the problems will come, and we will all have to face the problems. I'm giving you this lecture from Rhodes, Greece. It's a beautiful island in Greece. Hopefully, COVID will not be here next summer. We offer courses in my clinic. It's up to 8 people come for the course, and we do an extensive course from patient screening to implant placement, soft and hard tissue grafting, and final restoration delivery. Basically, we try to teach our participants very simple protocols that they can be predictable, can be easy to apply. But most importantly, you can visit Greece, visit Rhodes, and have fun and enjoy the weather. And with that, I conclude the presentation.
Okay. So, it was nice, as always. I hear it all the time with great pleasure. So, my friend, we have some questions, but let I start from where you ended. First of all, I've been in Rhodes, and it's very nice there, and I can spend there. I went for honeymoon, so I know it well. So
you are always welcome.
Yes, I know. Also, 75%, man, it's huge. I've been in the Congress of European Association of Osteointegration, which is ended these days, and they were all discussing to try to prevent it. It's the best way, you know. It's not that you can try to you know do something later. Try to prevent it. It's the way to go. Place your implant well. Place the supracrystal system well, and then stuff won't go wrong, or at least it's you do everything you can to prevent that things go wrong. Yeah.
Well, Guren, everything starts with implant positioning. If me as a surgeon don't place the implant in the right position, then it's almost impossible for the restorative, to do the restoration well. So we start with proper implant position, and this has to do with the location of the implant platform, 3-dimensionally. Then the second step is take care of the soft tissue, condition the soft tissue properly, record this, give it to the lab. The lab creates a design of prosthesis that has an anatomical design, like I said, providing for access to this plug zone. And then the final piece of the puzzle is for the patient to clean. You need these 4 things to happen. Of course, all these start from case selection. even if you do all this and you have a patient who is genetically, predisposed to hyperinflammation, very susceptible to bacteria. You have a patient that didn't take care all their life of their own teeth, the teeth that God, nature gave them,
which normally are the best. Let us say that, guys, we are not better than nature or God or whatever. We try to do our best, but nobody's got 100% success. Even though we can try to do it, you can't win all the time.
No, but for me, it's very important. For me, it's very important when the failure comes in the clinic, and I have to deal with this patient. Believe me, the last thing I care about is to charge this patient to redo an implant. That's the last thing I care about. What bothers me is how I look into this patient, and when they ask me, okay, doc, if we replace this implant, what will be done differently? I mean, will I have to replace this again in 3 years or in 5 years? I need to be confident. I need to be confident and know, okay, this is the problem. So if I do now things right, I know that he will not have this problem again. If everything was done perfectly, according to current knowledge, everything was done perfectly. Tell him, listen, I'm sorry, it was a mistake of mine to place an implant in you. You are not a good candidate for A, B, C reason.
Whichever reasons.
Which could be my fault or not my fault. For instance, we do have patients that they are allergic to titanium. It could be less than 1%, but we do have. We're not going to put every patient that comes in the clinic to go through allergy tests for titanium.
It costs a lot, and I believe none of my patients would accept it. I don't know yours, but
it's very low percentage for you to do this standard of care test,
it's difficult.
So that is important for me to know that, okay, from our part, my team did the best possible in order to provide high-end treatment.
It makes you sleep well at night.
Sure.
Normally, I did all I could. It's not that but it's important. It's lots of people like to know that they did all they could, and they couldn't do much more to avoid the problems. Something happened. A guy can crash nuts when he goes outside the clinic, so it's not something I can prevent. But however, if I did everything right, I placed the implant in the right position, I've got enough bone around it, because people, I see in CBCTs implants that hasn't got bone. You place an implant, half of it is outside the bone, and then you hope it will go well. You can't hope. It's something that it started like this. It will go wrong in some point. Hopefully, it will go wrong in 5 years, but it can go wrong even in 5 weeks. But we have also some questions. First of all, my friend Pavel asks, what about if the buccal is resorbed in relation to adjacent teeth? Will the pilot be initiated at the wrong location? So I believe you didn't took much time to explain how you start the drilling with the pilot. So it is assumed that you can place it only in the middle of the bone.
When I place implants in the anterior zone, the implants always will be placed lingually. Yes. When I move to the premolars, then it depends on the size, the buccolingual diameter of the cervical profile of this socket or ridge. So I might place it at the center or more lingually. When I go to molar sides, although in the past I will go for the bone, meaning I will move more lingually, over the last years, I have stopped doing that. So I try to place my implant at the center of the crest and then build whatever bone is missing. Now, in order to build some bone, this is horizontally, this is a very predictable procedure. It's very predictable.
Yes. I know.
If I have an 80-year-old patient, and I want to avoid a more complicated procedure, but in the molar side, when we place the implants more lingually, we see a lot of time problems in the restorative states, with screws being unscrewed, with implants breaking.
Biomechanical problems, mostly. It has to do with chewing.
So if I'm missing bone in the molar set, I will build it. In general, a problem that I see is that we tend to overbuild. We need to understand how much do we need when we try to build. I see some surgeons, they provide amazing results with humongous ridges. But do you really need that? Do you really need that? You need a good quality bone that will remodel throughout time under loading conditions, like the rest of our skeleton is doing. And you just need enough dimensions to provide stability. And then, for me, soft tissue is equally important to hard tissue. So you might have a great bone, if the soft tissue is not good quality, at some point you will see the effect on the hard tissue.
Yes, yes. That's why we try to augment all the time also the soft tissue, which can be done directly and which can be done later. But however, tissue is the issue, and bone sets the tone. So it's
a wise man said that.
Yeah, a very wise man said that. We're not saying names.
We can. Garber and Salama, these guys are pioneers. I mean, we follow their work. And also...
Actually, Linda said that first.
Well, Linda and the Göteborg group, I strongly recommend everybody to whoever doesn't have this book, they need to go and get this book and read this book. Up to this day, if you see my Linda book, you will see it's almost destroyed from how many times I read it. Because every time I learn something new that I already read, but I didn't really understand. So a lot of the things that we talk about today, they already answered these things back in the 90s.
Of course, it's amazing. You can go on to old literature and you see stuff that you think you know, and then you see that it has been done. It has been done before with success. So, other questions. Where can we get cervical is one question.
Well, the company has an online store at vpicervical.com, and also in different countries there are distributors. So if there is a distributor in the country of the doctor, I strongly recommend they go through the distributor, since they can get support and training. I strongly recommend to get some training before using the system. No more than 1 day training is required, this is the big advantage of the system. But it is important to get some training. Even when we buy a cell phone, we know how to make a call. But it is important to read the instructions, and if somebody expert shows us a few things, then we can jump into it and apply it fast.
Yes. Another question is, what's the cost of it? So we know we all we are running difficult times, with COVID and all, and we don't want our patient to abuse them with excessive costs. I believe it's the same for you.
I'm not involved with the sales of cervical. I'm mostly involved with the scientific part of the company and the research behind, and the studies that have been taking place, and the education. But I think, so I might be wrong, I hope I'm not wrong, it's about €1,500 to buy the premium kit. And I think there is also available now a more basic kit at about 900 something euro. Now, one thing, whenever I go to give a course, there is always a dentist tell me, yeah, Dr. Vergoullis, it's expensive. And I say, okay, take a step back. Take a step back. First, you need to decide if you believe in soft tissue conditioning. We need to start from there. If you do believe, then it's the most cost-effective solution, because you buy it once and you have it forever. It doesn't go bad. So you buy it once, you have it forever, and then if you do the math, comparing to any other type, meaning dynamic compression, temporary prosthesis from the lab, prefabricated anatomical abutments, 3D printed abutments cemented on a tie base, okay? After 15, 20 cases, you're already spending more money and more money and more money.
Yes, yes.
So we as dentists, we need to look at the big picture and say, okay, if I tend to work, my plan is to work for 2 more years and then I retire, then don't buy it. It's not worth it, okay? But if you have many years ahead of you, then it is worth it. And what really bothers me is that even me, I bought about 12, 13 years ago, piezotome. Okay.
Yeah.
Why? Because I could do my lateral wall sinus lift with less perforations based on some studies. And I said, okay, this is worth it. I will pay the €5,000 and I will buy this piezotome. I use the piezotome maybe once a month, especially if I do a lot of crestal lifting. I might not use it even once a month. So it also depends how many implants do you do, how much do you know? If you don't need it, if you do 5 implants a year, don't buy a cervical. You know, it's not worth it. Take an impression and have your lab make you a temporary prosthesis and shape the tissue with temporary prosthesis, because it's not worth it. But if you make more than 50 cases a year, then it is worth it.
Yes, yes. Oh, it's good to know, you know. Someone else is asking, please explain umbrella concept. Well, I believe it was something explained, but
you need to invite my friend Alberto.
Yes, that's
this is his concept.
He is, of course, invited.
Alberto is amazing. Basically, Alberto is it's a funny story. I met Alberto several years ago. I invited him here in Rhodes, where we did a brainstorming, and he's from Venezuela. My wife is from Venezuela. We ended up being known since he knew the family of my wife, you know, so we're very connected. We're very connected and very good friends, and he's an amazing guy. So basically, the umbrella concept is what I showed you today. A lot of these things is basically the umbrella concept, where Alberto, what he's doing is he's supporting the soft tissue zone, the cervical tissue zone, and then below that, as he moves into the deeper zones, he's telling you, provide more space. Give more space for the soft tissue in order for the soft tissue to have greater thickness, better blood supply, better quality. And this will give you better results. So I hope I'm not I'm accurate, but since I have been discussing implantology with Alberto on a regular basis for many years now,
I don't think he will mind.
The core of the umbrella concept.
Yeah, that's it. Oh, it was very nice to speak with you today, or tonight, because you know, we're all over the places, and I believe somewhere it's 2 o'clock in the morning, and the people are awaking just to hear you. You know, I thank you very much, and I hope to hear you again.
It was fun. I really enjoyed it.
Yeah, thank you. So, guys, bye. I hope you enjoyed it as we did, and I hope you learned something. See you tomorrow for the next webinars then, yeah? Okay.